Hi, my name is Randy, Chief Technology Officer of VDI Laboratory. Today we're going to focus on GI panels, a topic that I'm particularly interested in. GI is a very complex set of diseases and something that really requires a wealth of information for you to work up. And so as a company, we have been focusing deeply in this area, and I'd like to share some of those developments with you. So as you know, our services are context sensitive, meaning that you pick the services as appropriate for your patient based on what's going on. We have the general cancer panel, which is something that's useful for ADR and suspicious masses. We have the lymphoma panel. But today I'm going to be talking specifically around GI disease. We have two panels, major panels in this area called 228 and 260. These are our test codes, just to kind of get them memorized, if you will. The first one is the differential diagnosis between IBD and LSA, and it's where we started. All right, it's like, oh, is it IBD or is it LSA? Okay, that's where we started. But then it really became sort of like a point of, well, is it really just those? I mean, it can be a lot of different things. And so we came up with the advanced GI panel, 12 and beyond number of biomarkers, depending upon what you add to it. The base is 12, between IBD, LSA, pancreatitis, protein-losing enteropathy. We can actually detect protein-losing enteropathy, small intestinal bacterial overgrowth, malabsorption, deficiencies of vitamins and minerals, and then you can add to that as need be. So when we think about GI disease, it's complex. And to integrate all these markers, we're using the powers of computers. It's something VDI has been doing for a long time now. Those of you who have used our services are familiar with that. Everything's context sensitive. It all goes into the computer and everything's codified. And by doing that, we're then able to give you patient-specific comments and integration of these markers. And that's particularly powerful with the GI panel because now it's got 12 and beyond number of markers. And then we're looking for all these relationships. And let me explain how some of all this works. So we'll start off with 228. This is the GI lymphoma panel. Start off with cats, and now it's for dogs. And this is the Venn diagram to help simplify these relationships. So we have our primary tumor marker, TK1. We have our inflammatory marker, feline haptoglobin and canine CRP. And now we're adding B12 and folate. Why? Well, GI affects the pathology of the intestinal tract, and that affects absorption of these analytes, and therefore these are affected. And their relationships with the other markers are valuable. We're also adding signalment and age. GI disease is a chronic disease. Therefore, it's kind of unusual in really young animals. And therefore, we're using age as somewhat as a factor for statistical probabilities. And then, of course, like all of our panels, we're factoring in anything that might be anti-proliferative and anti-inflammatory, and steroids certainly fall into that arena. We do modify that in the neoplasia index, which sort of is the integration of everything. But always, and I tell everybody this all the time, if you can, please send us an untreated sample versus one that's been, subjected to steroids. That would be best. So this is the performance of the integration of all this data. This is the feline neoplasia index, so that's over here on the y-axis. And as you know, with our neoplasia index, it goes from 0 to 10, and then everything in between. Normal cohorts and inflammatory bowel disease fall below the cutoff. You can see that small cell, large cell, and sort of X GI thoracic lymphoma are marked accordingly, with large cell and other X GI lymphoma, very good separation. When we look at small cell, the median line is extremely separated, but there is some overlap. As you know, small cell is a propagation from chronic IBD. Damage occurs and it begins to move. Those markers begin to proliferate and move up, and hence there's going to be a period of overlap, and that's just a fact. Like all of our GI products, we always say if you're going to try to make a non-invasive diagnosis, it's best to do that not only with our markers, but also with an ultrasound. We can never tell you the source of the TK or the CRP. I mean, it's just in the blood. That's where we're measuring it. But in context to imaging, then you know that it's coming from the intestinal tract or from some mass or whatever that context is, and that's what's important. Now, for GI lymphoma, you can see in this particular study that was done, we had an area under the curve of 0.86, sensitivity and specificity accordingly, and so the performance overall is quite good. This is the report. Now you can see how we integrate B12 and folate into the results to come up with then the indexing of the neoplasia index, incorporating TK1 and haptoglobins for cats, CRP for dogs, and again, context sensitive. And then everything on this side then will tell you what's going on with this particular patient and what that most likely is. And in the case of cats, we can actually give some reasonable guidance, small cell, large cell, but it's not the same as histopathology. Never say it, we even make disclaimers on the bottom, and I want to be clear about that, but it does provide some guidance for you as well. Now, on the B12 folate report that is part of this, we do give you the B12 result and the folate result, but we'll also tell you how to fix the B12. This is a common thing with like vitamin D, magnesium, B12. These things are dietary derived, and hence, when possible, we'll just tell you how to fix it. And the dose is specific for that patient. So we take the data that you give us, and then we integrate it with wherever that level is, and then we'll tell you exactly how much to do. And then we'll also tell you when the next retest date is, because there is an equilibrium, a period that needs to be happen here. Now, the other thing that we do is kind of cool, is we plot this data. Why would you want to plot B12 and folate? You know, I mean, so here's folate, here's B12, and we plot it. And the reason why is because these are absorbed in different parts of the intestinal tract, and there's different pathology that's going on. And as a result, between the two of them, we can give you some indication just from two tests of kind of what's going on. Like, you know, if folate's high and B12's low, you know, there might be possible bacterial overgrowth. If, you know, conversely, folate's low and B12 is normal, there might be dysbiosis, or maybe when it's high and low here, B12 is high and folate is low, there might be overuse of antibiotics, sort of the flip side of this equation. For lymphoma and those types of diseases, they tend to fall sort of into this zone over on this side, and we use this data to help give you the answers that you're looking for. Now, in the case of more markers and other diseases, what we've assembled now is the advanced GI panel, and this is 12 biomarkers at a minimum. You can go beyond this, patient signalment, and the power of computers to give you multiple Venn diagrams or looks at all these different markers for the questions that you're asking. So is it IBD or LSA? Well, we have a diagram for that, if you will. Is it pancreatitis? And we're running CPL and FPL, but it's not just that. I mean, one marker alone, and I know everybody runs CPL or FPL, pancreatic lipase, but you know, it's not a perfect sensitivity and specificity, but we have a way of improving it by incorporating these other markers. The same is true now for protein-losing enteropathy. We're able to actually give you high confidence there's protein-losing enteropathy that's going on, and other types of things, looking at the vitamins and minerals in terms of bacterial overgrowth, malabsorption, dietary deficiencies for sure. These are things that we can easily bring together. Now, with all of VDI services, we have a dashboard to try to quickly communicate to you what's going on in that particular patient. And we use a lot of colors because color just communicates fast, right? And so if you look on the right versus the left, well, on the right, you see yellows and sort of pinkish reds, right? And then on the right, you see a lot of green. Well, which one's worse? Well, obviously the one on the left is. And the one on the left here, and if you look down here on the lower left-hand side, chronic enteropathy. So in this particular case, we highlighted that it's lymphoma. We gave you high confidence. We give it an LSA clinical score. So if you tell us what's going on, like weight loss, vomiting, diarrhea, and inappetence, we'll actually grade it. And then we give you what our confidence factors are. Why are we coming to this conclusion? Well, in this case, we had a positive NI, high TK, positive inflammation, low B12, and a 3+ clinical score, all brought together, high confidence. On this side here, we had pancreatitis, high confidence. Why? Because we had FPL, we had a 3+ scoring on the clinical, and we had low B12, common thing that happens with pancreatitis. So again, we're bringing a lot of these markers together. On the right-hand side, this is a pretty normal situation, nothing particularly to write home about. Then what we do is over here, we tell you, hey, maybe you should be looking at food-related allergies. Maybe you should be looking at, hey, Addison's disease, which can mimic GI disorders. So run a cortisol, and we can do that for you. And so these kinds of things are helpful for the workup of the overall case. So let's take a look at this one in particular. This one in particular, again, had a positive scoring for lymphoma, FPL, and other parameters for pancreatitis. We did not see protein leucine enteropathy, and the essential vitamins, there's a little bit low on vitamin D and B12. And if we look at the subsequent pages, you can see how this works through. Again, these markers come up to a high positive index, and these are context sensitive. We look at B12. Oh, it's low. This is what we tell you to fix it. And sure enough, it's falling sort of into this sector that's often common when we look at lymphoma cases. Over here, we're telling you, hey, the vitamin D is a little on the low side. For this particular patient, we have a multi-marker dosing algorithm. It's not just based on weight. It's based on a whole variety of different factors. And we then tell you exactly what to do for this particular patient. And then we tell you what the retest date is so that you know how long that equilibrium period is going to be before you need to retest. In this case, this patient was magnesium sufficient, but if it was insufficient, we would then tell you exactly how much to dose the patient accordingly. Now, a new thing that we're adding right now, but it's just almost done, is we're now looking at the effects of all these different therapies to be able to tell you whether therapy for these GI diseases are effective or ineffective. So here we start tracking historical values. So we'll see TK value, in this case, drop. Well, that's a good thing, right? Here we're looking at historical inflammation. Inflammation dropping. Again, these treatments affect proliferation, they affect inflammation, and then they should move towards bringing things back to normal. This patient, which was being treated with corticosteroids, chemotherapy, and antibiotics, which is listed right here, then are telling you that this is effective treatment based on the history and the response to therapy that these markers then are derived. Our program now is encompassing a lot of these different types of standard treatments. We're even beginning to look at different botanicals, because many of these things are being employed by different types of clinics, and hence we want to serve all of the spectrum of everybody's needs. If you just check off which ones you're using accordingly, then we will input that into the computer and then tell you whether something's effective, ineffective, marginally effective, as the case may be. So I hope you find these services to be useful. GI disease is a complex disease, and I think the AGI 12 panel will be something that will be very useful for you in your clinic. Thank you for listening to me.